Welcome everyone to our Buncke Clinic series of virtual visiting professors. I am Bob Aksafa, and along with my partners, Drs. Greg Buncke, Rudy Buntic, Andrew Watt, and Walter Lin, I'd like to welcome you all to our series this morning. We have the distinct pleasure to welcome a global thought leader in the field of hand surgery and in the field of congenital hand surgery in particular, Professor Balakrishnan from Chennai, India. Professor Balakrishnan is Professor Emeritus at the Tamil Nadu Medical University, and he's the Medical Director and Chairman of Wright Hospitals and the Wright Hospital Skin Bank. I could take a lot of time describing Professor Balakrishnan's accomplishments, but I'm just going to list a few of them in the interest of time. He is the past president and the present managing trustee of the Indian Society for Surgery of the Hand, the Indian Society for Microsurgery, and the Brachial Plexus Group of India. He's also the past president of the Association of Plastic Surgeons of India. He received the Lifetime Achievement Award from the Tamil Nadu Medical University in 2012, and for the Sake of Honor Award from the Indian Society of Peripheral Nerve Surgery in 2016. He also was granted the International Federation's Pioneer in Hand Surgery Award in 2019. Professor Balakrishnan has given many has gotten many oration awards, as you can see here. I'm not going to go through the individual details, but you can see that over the last 20+ years, he has gotten some of the most prominent and prestigious oration awards that one could get. He has authored over 300 peer-reviewed papers, written over 17 textbooks, and was also the editor of the second volume of the Textbook of Plastic and Reconstructive and Aesthetic Surgery in 2017. So clearly, you don't find too many people who have more experience and have accomplished more than Professor Balakrishnan. And for that, we are very, very thankful and very honored to have you give us a talk today on your 4 decades of experience in the field of congenital hand. I want to welcome everyone from all over, and especially all of our friends in India. Professor, I'm going to find you in this list and give you control, and that way you can share your desktop with us. Great. Thanks again for being with us today. And while the professor is giving his lecture, I will ask everyone to please turn your microphones off so that we don't have any distractions during the lecture. Thank you so much.
Am I right? Can I go ahead?
Please start. Everything is great. Thank you.
Thank you. Good morning to you, Bob. At the outset, I should thank you for inviting me to the presentation of Buncke's virtual professor. And now I can show you the slide on your left. This is the institution. It's a public hospital where I worked for more than 30 years in this hospital. Then after superannuation, I started my own hospital, the boutique hospital. Compared to this is miniature, and I've been working here for the last 15 years. That's why I said my insight on congenital hand differences goes back 4 decades of my practice. Now you could see I'd like to show you the different congenital hand differences. There are myriads of congenital hand differences. You'll be surprised to see them all in one screen. And you know, after them, read a lot of knowledge, training, and expertise. There's a good proverb in Tamil that says, what you have learned is only handful. What you have to learn is the size of the universe. That's true. That's true for everything in this world on education. And especially, I'm so interested in congenital hand difference. I've seen over 3,000 cases of congenital hand difference operated nearly 50% of them. I'm going to show you some of the few which I have thought is very important, and then also people will understand. Now, another rewarding thing is that this girl at the age of 4, I have operated for microsurgery, operated for macrodactyly. And you see the thickness of the middle and ring finger, and there is also big swelling in the palm. Though not much pain, she was disfigured and all the colleagues used to comment on her. So she wanted to have a surgery. I did the surgery, and then she was okay. And I'm not very happy with this because to prevent the growth, I have to clamp the PIP joint. So even now the flexion is good, but the PIP is less. But they are happy. Parents are happy. She got married. All the cards are mixed with this Rangoli box, which she made prayer to her marriage. And she was kind enough to post me this picture when I requested her. Now, coming to the subject proper, what you see here, the incidence is 1 in 600. That means it's so common around the whole spectrum of hand surgery. And if you look at the etiology, 60% is unknown. That is still surprising. So many patients know, we could say that etiology is unknown. 30% have a genetic background, be autosomal dominant or recessive. What the cause is, say is the parental consanguinity or prolonged infertility and increased maternal age. The parental consanguinity is very common in the Asian population. That's the only thing I can attribute. 20% is environment. That is, one is intrauterine, where you see the amniotic membrane rupture. Many times the ruptured amniotic membrane can go around the uterus itself, where it go from the make a small ring around the finger to an amputation of the finger. The extrauterine causes mainly between 25 to 50 days. I'll tell you why the 25 to 50 days. The pregnant mother should not be exposed to drugs, radiation, or viral infection. Most of the time, when they are exposed to this, they could develop a child with a congenital heart disease. If you look at the embryology of the head, the hand buds develop at 4th week. The vessels incinerate on 30th day, nerve growth with on 36th day, and finger separation happens on 47th day. The muscle formation, quantification happens on 50th day. That's why I said between 25 to 50 days, the pregnant mother should not get exposed to drug or radiation or a viral infection. Coming to the timing of surgery, it's always been told, the old teaching is that before school going, because the child will be mocked by your friends. So before school going, you do all the surgery. But today's teaching is that we like to have it done before 18 months. Many times we do at the age of 6 months, and most of the cases are done at the age of 1. And it will be always better. And over top, you will understand why I'm telling this timing before 18 months be done for the children. The only difference is that whenever you want to do a tendon transfer or a procedure where you need a command to the child, it has to be delayed for 2 years. Otherwise, all the rest of the procedures can be finished in months. There are not many contraindications for the surgery. The surgery is contraindicated like the case like what we see here, a radial dysplasia, where you have a straight elbow. Go do any surgery for the child cannot reach the mouth. The surgery will worsen the existing function. Only this is the case where you should not do the need corrective surgery for this type of case. Looking at the classification, there are many classifications. Swanson gave a classification first, and the International Federation is codified classification. Then Warburg, Pansky, and Michael Tonkin, they also made a different classification. And Nelligan also introduced another classification. But I tell my colleagues or my fellows, read all the classifications for the purpose of exam. But I always teach them in 3 different things. One is pre-axial, relating to the radial border, central deficiencies, and post-axial, which is to the ulnar side. Today, my lecture also going to be on the same sequence. Let us first take the pre-axial congenital hand difference. Why am I putting this trigger finger? There are a lot of controversy whether to operate or do like a conservative type of treatment like needling or straightened finger or printing. No child will go. Many of them trying to put in a needle and then try to rupture the fibrous structure sheet. I have seen myself many cases wherein they have lacerated the tendon, gone for adhesion, then they even the rupture here that. And you can see clearly a nodule. It's not a nodule, many times they say it's a tumor. It's nothing but the swelling of the tendon prior to the flexor sheath here. That is been marked here. And you can also see a bend in the here, IP joint. You can also see here. So this surgery always I undertake. Back, can I ask you something? This my right side corner of the screen is closed. Pictures are not seen.
I'm sorry, can you repeat that?
See the right side of my screen. Got all the names and the presentation
yes.
also. That
Yeah,
please clear that so that
you can minimize that. There's a button to minimize that so it doesn't get in the way of your slide. We don't see that. Only you see that.
Okay. All right, then it's fine. Perfect. If you are able to see my entire slide, not a bother about it. Right.
Yes.
So we're not able to see the slide.
We're not able to see the slide. Now?
No, we can see the slide. I can see the slide.
Now,
Yeah, I can
this,
see your slide perfectly fine.
Yeah,
Go
right.
ahead.
I see always we do this under some sedation. That's we give 5 milligram of ketamine, of course, by the anesthetist. He's going to monitor the child till the end of the surgery. Once you give the IM injection, intramuscular injection, child will go to sleep and you can easily get the child away from the mother, take inside the theater. And they make a small incision on the MP joint crease. And then once I done this incision, inside I dissect vertically or I'll go vertically. The incision is transverse incision. Once you do, I do this to protect the distal nerves on either end. And once you see that, you can see the sheath here, which you can totally excise. And also, you can always do a flexion of the finger. And the child will be quite asleep and no further sedation is given. When you given that to the mother, child will go to the room and start immediately moving the finger because they're closing the wound. We always use a non-absorbable suture material like Proline so that we can remove the suture by the next sedation and then taking them out. This is how we do. This is such a simple procedure. I don't do any other procedure for the trigger finger. Then the major problem on the radial side is thumb hypoplasia. As you can see here, thumb is not in its usual place. It's placed in the middle of the palm on the radial side. The pinch, grasp, and final activities are efficient. If they are left alone, they develop lateral pinch. Surgery improves function and osmosis. Most of the patients request to do something to have an opposable thumb. And at the same time, they also request to have the 5-fingered hand, not 4 fingers. Now you see in this, Muller has thumb hypoplasia. I have classified it into 4 types, and Bloch has further classified in 1967 as 5 types. And I show you this slide. Type 1 is minor generalized hypoplasia. No treatment is required. I will show you a slide for the case. Type 2, there is absence of intrinsic pinna muscles. First, rib space is narrow. The ulnar collateral ligament is sometimes insufficient. The main thing what you are doing is release the thumb width. That's very important. The UCL is insufficient. You reconstruct it either by suturing the ligament or with the tendon graft, and you have to do an abdominoplasty. Child in type 3, similar to type 2, plus extrinsic muscle and tendon abnormalities are present. More than that, skeletal deficiency. That's where Mansky and Buncke came divided into 3 types. Type A is a stable carpometacarpal joint. Type B, unstable carpometacarpal joint with a short metacarpal. Mansky called it as type B. Type C is no metacarpal, named by Buncke. When you do this procedure, many people have tried for reconstruction to make a thumb. But all this they're done by a vascularized free joint. So many things they have tried to do or do a toe transfer. All of them are not given a very good result. So everybody end up with pollicization. But what we have introduced is toe phalangeal transfer. This was taught us by Alan Gilbert when he visited our hospital for one of the surgical workshops. In type 4, post-frontal or floating thumb, the request is mainly for pollicization. We are just thinking and making ourselves try to do even here pollicization, provided the thumb is kept in the middle of the palm. Aplasia, absolutely no question, we have to do a pollicization. Now, you see that thumb type 1, the thumb size may be small. There is no functional deficit. When you have done an X-ray, you can compare that the bone size is smaller than the contralateral side. No treatment. In type 2, you can see a short thumb, pelvis contracted, and position is also. So we have done a Z-plasty to the thumb web release, and then we can also do a Hubert transfer here to have a upper wrist. I will explain to you later about it. In type 3, as I told you earlier, the severe hypoplasia, very small thumb, web space is narrow. Type 3A has all the metacarpal and series of joint. Only what is lacking is the opposite. Type B is a tapered metacarpal and absence series of joint. Type 3C is where there is rudimentary metacarpal or no metacarpal. Here, many reconstructive has been done, not to the effect of pollicization. So now here only we have now planned for a pre-toe phalangeal transfer. This is just to show you type A hypoplasia. Web has been cleared. We have done a Huber's transfer for you to get a thumb. Then about 15 years ago, if you ask me, type 4, where the thumb is placed in the middle of the palm, on the type 3B, where the thumb is very close to the base. If you ask me today, I'll be probably telling you all, everybody, that I'll be doing a pre-toe phalangeal transfer, which I'm going to show you. But those days, what we did, bilateral pollicization, that is the result. So now the pre-phalangeal transfer indication is, even in the floating thumb, you have a broad base, and also you have a bad index like this. It's not a workable index. The choice is pre-phalangeal transfer. Type 3B, what you see here, is the best to do the type 3B pre-phalangeal transfer. Now, when you do this pre-phalangeal transfer, it should be done before it. You can take 1 or 2 phalanges. Proximal phalanx in the third or fourth toe is taken. The second toe is always kept without disturbing, so that anytime you want to use a toe transfer for this kind of difference, you can use it. When you remove the toe, it should be extra periosteal harvest and fixation with K-wire for 8 weeks. All this is because of the parents' request. In Asian population, everybody wants 5-fingered hand for their kids. So now, the step 1 of surgery is this. You open up the base of the thumb, short thumb here. But you have opened it, there will be a vestigial tendon, what you see here. This is the tendon, is abductor pollicis longus tendon, which is vestigial, which is tagged and kept ready. Then the second stage, here we have harvested the toe phalanx from here. When you do this, we never go to the bone, we go to the joint straight and open the joint both proximally and distally. Don't disturb the artery. Fix it with the K-wire. Again, bring it here, already the place where you made an opening, fix it there with the K-wire. The last picture, you see, I'm showing a different toe because here we have taken the third toe. What we do normally to prevent the recurrence of the toe, we suture the flexor and extensor tendon very tight, continuously, so that you'll have a straight toe without any recurrent deformity. And the third stage is this. We do an opposition. Huber's transfer, digital minima is taken. Digital minima. This digital minima attaches a screw slips, one to the proximal phalanx and other to the extensor complement. So what you do, we take both the tendons and bring it subcutaneously. When you are dissecting it, you can go down up to the level of the pisiform. You should not disturb the attachment of the flexor carpi ulnaris. You can always identify the distal vessel down here, then try to bring it subcutaneously. Switch it here to the base of the phalanx, what we have put there. This is done only after 6 months after the prephalangeal transfer. Once it goes to the base of the phalanx, the other suit goes to the dorsal capsule. Keep it steady. And this is the reconstructed thumb, what you see here. You can also see this. Palmar scar is so nicely setting. You can see already the opposite. And you see the video. You can nicely see how the child, this is taken about 3 months after the surgery. Child is able to oppose. Only opposition not possible is to the index, which will come in a couple of months. But we don't have a. But this is one of the good procedures we got exhibit here. Next, this is a next case where there is a type 3 thumb hypoplasia. 3-toe phalanx transfer has been done. Approach class done. You see this is the one. Only the depression what you see here. Some mothers are asking for what you do. That the child grows up with fat there, or he himself grows up fat. And you see here, how the small child, just 1 year and 9 months, picking up a small object with his thumb, able to take it from one plate and transfer to another. Very nice, good application. Fortunately, it's also the left hand. It's not with the shoes. And you see here, this is the type 3C. You can see the thumb, which is kept at the middle of the radial border of the hand. So when you see the X-ray, there is no metacarp. Very small amount of proximal phalanx is there. What diagram we call type 3C. For this, to have the length, we taken the two phalanges. Third and fourth phalanges have been taken. Both of them have been fixed. When you do this fixation, you remove the cartilage here for a better union of the bone. We want to have a good bone contact. And then whatever the residual tendon has been referred to be distal and the proximal phalanx, both the phalanges. This is now you see this child came to us at the age of 10 years. We are 10 years, we are not really happy to do a free toe phalanx. But they insisted that everybody say that you give 5 fingers. So we are forced to do a full phalangeal transfer. That's what the slide you see. You see a nice good and this is what the case came at the age of 10. Reconstructed. Now, this is the age of 70. What she's now doing is nicely using the pen, the right hand. See a nice good handwriting girl. Also, you can see her nice good handwriting girl. Of course, he uses 3 fingers, but still, he's very happy. He didn't come for any upfront plastic. They refused to have any second surgery. Now you see here taking a bottle like that. So the span is also good. I think it was all of you agree with me also that it's a very useful procedure. I have parents request for a 5-finger pack. Type B or C. Now coming to type 4, post-mortem, there is a rudimentary which is attached to the radial side. Today the child comes to me like this, where the thumb is placed in the middle of the palm. I will go for a double pre-phalangeal transfer. But mostly the advice will be rationalized toe joint what Akima has tried, but it's not very effective. Everybody will go for pollicization. Because it's not, though this finger is there nicely, good base is there. In this base, the neurovascular bundle for a pre-phalangeal transfer. Again, thumb type 5, aplasia, there is no thumb. They can see autopolicization. The index is turning towards the middle finger, trying to oppose middle finger. There is no choice other than doing a pollicization. While coming to the pollicization, they have been using this Buncke since the master Hamburg, who has taught us all the technique. Now we follow Alan Gilbert technique, where the incision is taken up to the neck of the man on the collar side, and then we don't make this split in the dorsal tissue. This splitting only sometimes makes one of the skin flaps to go. So instead of that, we just take the extra skin here, and what we do, the same racket incision of the dorsum of the index finger. From the middle, we take a concave and convex incision, the transverse line drawn here. This is the base of the thumb, as you are going to do reconstructor. Thumb here, pollicization. Pollicization only. Whenever you do that, this is the base that will come and we remove this extra digit, whatever. So this small incision change. Another one is identification of the vascular sublective, not whatever there. Index finger. Many times you may have this occupant now where the common distal vessel is running between the ulnar side of the index and this is radial side of the middle finger. Then you have to divide the vessel, separate this vessel, separate the vessel. The third one is venting of the pollen. You are going to use the entire proximal phalanx as the vector. So there is no need for any of the exercise or just vent the fully. By taking the metacarpal, total metacarpal is retained. Another important thing is that you must totally to allow the parrot to stay, phalanx will grow. So this is just to show you a diagrammatic representation how the two introsections, dorsal and phalanx, venting your fibrous structure sheet, or metacarpal, only the head is and is fixed with two K wires. Those days we used to fix them with suturing technique. Now one wire comes straight from there down to the top. And you see a turning of the end of the second metacarpal. It's totally turned like this so that there's a small place for the extension of the CMC joint. And this positioning you fix it and the other wire goes to the dorsum, can be removed. And then this is the fixation what I already shown you. And then finally, the muscle balance. Buncke advised shortening of the common extensor tendon. We also taken EIP and fixed to the base of the proximal phalanx. And we don't do anything, both the procedures, we don't do anything for the flexor tendon. And he takes both the intraocular muscles, hook it to the extensor extension. They are sutured at this part. It's a good procedure. We have done many cases like this. But today, what we do is, Alan Gilbert told us, we create a space between the dorsum of the proximal phalanx and the skin pattern on the extensor. And then on that place, we suture both the polar dorsal intraocular nicely. That will do all the muscle balancing. And you can see a reconstructed, pollicized thumb will go on the pose. That's all the function of the regular pollicization. So there is no difference. Instead of doing all the cutting and the suturing, you have to fix the intraocular muscles just below the extensor tendon. Coming next to the pre-axial polydactyly, it is also common deformity, 1 in 700 live births. More common in Oriental population. A delayed involution of the apical ectodermal is disorder of interaction between pre-axial ectodermal and mesodermal is possible. There are many classifications being given for this duplication, but still Gass's classification still holds good. You see here, I tell my fellows this way. The first and second involves the thermal phalanx, third and fourth involves the proximal phalanx, fifth and sixth involves the metacarpal, seventh is the triphalanx. In the first, thermal phalanx may be a web like this or separate. Same thing, third and fourth, either it is just split or two separate phalanges. Metacarpal again, split or two phalanges. This is the way easy to remember this. And then reconstruction comes, just not an ablation of an extra. Assembly of two duplicated get optimal form and function. Aim for adequate size, good web span, stable joints, good power and wisdom. When you insert the intrinsic tendon, the ulnar side is meant for super, radial side is for. More importantly, you have to refer the radial collateral. This is just to show you a type 1, which is does not need any surgery. You see a broad line. After surprise, I took an X-ray. You see a broad palate, thermal palate. Does not need any surgery. I don't even admit it. Again, another interesting case, bifurcation. Type 3. You can see 3 phalanges. You see the X-ray. The metacarpal is type. There are 2 thermal phalanges and accessory come on the radial border. But the patient refused any form of surgery. Okay, keep it with you. So how I do it for the type 1, where there is a squint line, take away the center bridge like this. Because I have not got no case to show you, but this is the best way to do it. Remove the center part of central bridge incision. Suture. Here there is no need even to repair, just to repair the bone. Coming to the type 4, 3 and 2, I don't have cases to show you. In 4, there are 4 types spread and this is the 4th A type is there, the accessory thumb is hypoplastic. Type B is thumb is ulnar deviated. Type C is a divergent type. Type D is a what I'm going to show is convergent. As you all know, this is a good thumb. So what you have to do is exercise this. While you exercise this, not only exercising this, you must make an object so that you make this come down. Also, narrow this couple. You have to repair the radial collateral. Insert the effect of pollicization. It looks good when you small angulation here, which they are not bothered because of the extra skin, which they don't want to remove. All of them feel that once and now they are happy with the function, just leave it. No cost. This is the duplication at the metacarpal level, type 6. Here we have to access the radial. You see here I followed the suit. This metacarpal is only this phalanges are there. Look at the ulnar side thumb. So I took it an island and I removed this proximal part of it. I retained the proximal part of it. Remove the entire skin, deglobed skin over the thumb there, like the on top plastic. Island. The existence of the radial component. You are such a good thumb. And this is a triphalangeal thumb. This accessory ticket. Remove this reconstruct this ligament. So my bone piece of bone that needs to be removed. This incision. Delta phalanx. And it is a bilateral 5-finger action. Right here. To make out, all the 5 fingers are left parallel to each other. All of them, the thumb also had 3 phalanges. So what we did, we put this on both sides, bilateral phalanges. And when we are discussing the parents, we said we first said we do it on the vertical. It works well, will come on the right side. So we did on the first side. Though the thumb had in the right. See that though we have done everything. Like next. thumb and the index is using. Whereas this side also is not. We do this pollicization. Only thing is every movement is able to do. The only thing is the paucity of it. So they said they do a transfer, we must transfer. So when I told them the child become older, bad drop here, but you are minutes. But that they are happy. Now they are ready. Corona goes, they'll come back for surgery and radial dysplasia, all of you know, known as the radial plummet, don't call it radial plummet anymore. Dysplasia. The treatment protocol starts on the day one. But they told that the child has got a plummet. You have to make a splint and stretch the hand of the day. The correct splinting should be learned throughout the day and night. See that, tell the mother to see the rest of the hand. We have to have a splint. And we always do a radialization at the age of 6 months. Pollicization. Yeah. Maintain the wrist position until completion of the pro. You do a radialization, pollicization. There are always some amount of radiation. We advise them to wear the splint mainly at the time nights. And this is the child which I showed you. Such a small bowing of the radius that you can see. Take a split. And when I do a radialization, my preferred position is David Evans bilocal plan. The tight skin here, radial side is a good also. This is sometimes a problem. Sometimes all necrosis, not necrosis, more tough. Skin changes in the skin in the blood, but being a child, don't worry. Just allow the child to grow. And I show you my case also. Now the policies, realization is not policies. Having picture. Good opposition. Now, so this is my this was done in 2 stages, but I like to finish it before the end of 18 months. So having finished the pre-axial deformity, let's go to the central hand. We have very interesting things, syndactyly, camptodactyly, clinodactyly, and the club hand. Coming to the syndactyly, it's again very common, 1 in 2000, and 10 to 40% of the family history. That's why when a child comes syndactyly, ask for the history of the parents, the cousins, and relatives. Anybody else have a syndactyly? Have they done any surgery or still using the hand? In any adult syndactyly, they are used the hand more often. Coming to the types of syndactyly, all simple and only the skin is called complex. Sometimes it makes syndrome, airport, pollen, and so on. These are some of the types of syndactyly. Points to ponder in this is acrosyndactyly is only the tips of the fingers. This should be released as early as possible. Just snipping the tips of the fingers can allow the growth to happen. And the marginal fingers do it at the age of 6. The rest you can do. Multiple digits syndactyly, adjacent size not separated simultaneously because you run shortage of skin. See, this is a case of acrosyndactyly. Middle 3 fingers are greater like this. Just the small amount of skin is joined here. Not a pollicization. Introduce this markers here. So you got a web here. So what you are doing is put it the pencil. That is enough. This is the final picture. Further to grow. Again, another case of syndactyly what we see here. This syndactyly only in the tip, what we observe here. Then we released this. Here, pre-operative see can give some parts of it. End of 4 years. Now they are waiting for the last 2 years. Syndactyly technique is you see a classical syndactyly. marking is very important. Excision of the pad maybe you can do, or many times I don't do it because many times I was able to have a good flap with it. And always use a full thickness so that you don't have any small contraction on the. Avoid a web 3. This is a very important step. Avoid a web 3. You use a full thickness flap on the web and also on the sides of the web so that you avoid a web 3. I'll show you the cases. Nail fusion is also very critical. Separate them very nice. For the flap, I now follow the omega flap technique. This technique again was introduced to us by Alan Gilbert. This is the omega flap on the dorsum. It's a triangle which goes up to the PAP joint. The triangular flap, what you can see here, one triangle in the center of the finger, and then one triangle on the middle of the middle finger and one on the ring finger. And it's a truncated. This much width of the flap is enough for you. On the volar side, what we call is the anchor incision. This incision is again drawn from the PAP joint on the volar side. It goes down where you decided to form the joint, the other tips of the fingers. And we also draw two triangles. These are the two V's. They are distally placed triangles. These triangular skin will go to the side to create a good web space so that you don't have a web creeping. Distally, it is a opposite of what we have done on the dorsum, G-plasty, and finally it's a straight incision. And this is how the dorsal flap comes in and sits here on the volar side. And on the flaps are sutured, and in between, see that you've got a graft. What you are seeing is in between flaps, you do the graft, full thickness taken from the groin. And for the nail fusion, Buncke grafter is given a very good idea. Why? Because when you just separate the bone like this bone will never keep quiet. This bone is going to grow more and to produce a polydactyly rotation. That's why Buncke grafter described two parallel flaps on the tip of the finger based on each finger, one on the right, one on the left. And then these two things are done. This flap can be used to hold the terminal phalanx like this so that we can avoid the problem of the rotation. Now I'm going to see a case of a complex syndactyly where you can see the syndactyly and also there is a union of the terminal phalanx here like this. And this has been followed by omega flap technique. I'll show you the result. And before that, this is the omega flap drawn on the dorsum. This is the anchor which is drawn on the forward. And when you have done this, this is for good web here. Both the fingers. And in complex fenestrated syndactyly, again, it's a simple procedure. You can just separate them. Again, no, you can always put a stick or something to separate the web, and then you can remove this. The excess skin has been removed, and the finger has been separated like this. Now, I like to show you multiple syndactyly. Bilateral hand. See this side, all the four fingers are united. Left side, one is absent. There is a syndactyly between the middle and ring finger. This to the right hand side, we have to do separate the middle and ring and little, and again index and middle finger using the same anchor incision, dorsally, omega flap. Same thing done on the left hand side. Same sitting, both hands are being operated. This is the result. What you see here is a good web. All the four fingers. Years follow. You see that nice good movement. Only thing now they want to have and capped out actually is another interesting condition that happens. It's a painless virtual contract. Initially, we'll ask the mummy to stretch the finger, but many times it never happens. We give the spring only in the daytime to keep it gradually progressive. So at the end of 6 or 9 months, we have to take it up because if you don't do operate this, they are reducible or a flexible joint become irreducible joint. It can be congenital or acquired or syndromic. So you should take these cases before 1 year to operate. You see here, I just showed this. I don't have an operating slide, but you see here where I sutured here. I go through the neutral line because this being on the other side, and then I open this. Once you open this above the neurovascular marker, I expose the pressure sheet. Once you open that, open the A2 or A3, and you can lift the flexor tendon out. And the posterior flexor sheet, you can cut along, then you can reach along with the wall of it. If need be, you can also make cut in the axis. And then try to stretch this finger with the finger straightened down. And you can, after that, you can do the split, make it straight and in between. See this boy now. This is what we are done here. He is now he is 8 years. Still the fingers are straight. Now you can see here. So happy that they're able to do that, they're able to show you straight finger which he had after back to the side. Now to the clinoidactyly, it's again in a very small percentage. Where there is an angulation of the to the epitoid. Most of the time we have a delta phalanx. You see the problem occurring in the middle phalanx. Maybe a delta phalanx or a shortened phalanx. If the shortened phalanx, you can do osteotomy. Delta phalanx, just remove and fix it. Only what the problem is short finger. Can the clinoidactyly can. Then coming to the other major component in the central hand difference is the cleft hand. The cleft hand, originally called as a cleft hand, is now divided into typical and typical cleft hand is a central logical defect. You have a V-shaped defect. You may have the third metacarpal. You cannot have the V. Whereas in the sim-directed actually, you have the thumb, which is near normal or shortened, and all the other 4 fingers are small nubbins. Little finger may be better, but the middle 3 fingers are small nubbins. Called in a typical cleft hand, what is the defect in the middle finger? Metacarpal is only proximal third muscle. So we raise the flap based on the polar side, and then raise this flap, and then this flap was drawn in between the web. So the thumb web is well formed, and then you can fix the index finger onto the base of the middle third metacarpal what was available, so that you have a good length and this web is formed. Show you the post-operative picture. This is the cleft hand. So after 6 months, this is 10 years. And this is another type of a cleft hand. The small cleft here, when the third metacarpal is present in this case, and I showed you the X-ray, there is a proximal phalanx of the middle finger is kept across between the 2 joints. Metacarpal is present. The thumb web is good. So we now transfer this index finger. So this is the X-ray of the child. See the PPX of the middle finger is like transfers like this, involving both the joints. What you make a central incision, remove this transverse phalanx, and then you see that because of the good web, I didn't try to shift it, and this defect will go slowly. It's able to do all. The child is just 1 and 6 months or 1.5 years, 8 and 18 months now. As he grows, it should be correct. Coming to the sim-brachytactyly, first I want to show you the Pollard syndrome. First identified, and they said it is a very congenital webbing short webbed fingers. And it has got a problem of the loss of sternal head of the pectoralis majoris, as you can see in this video. This is because of the hypoplasia of the subclavian. There is also absence of the all the fingers are fused and they are also short. Coming to the syndactyly, different types. There are 4 types. Polydactyly, that is a single finger. Thumb is here, but still it is small. They got 3 nubbins to represent the middle finger. They got 1 more finger up. What we have done as usual, to deepen the thumb, we raise the good dorsal flap, get it there. And in the second stage, what we did, have an opposing finger, we put the second toe. We use the whole toe because, as usual, when you have a short thumb, you must have long fingers. If you have a long, nice, normal thumb, you can have a short. So we have done a toe transfer. We are able to make pulse to pulse pinch. Slowly, this will bend and this will also grow. So ultimately, you get a good result for polydactyly. And the syndactyly, what I showed you, the post-operative picture, you can see the big dorsal flap create a thumb web here, and this is 2 years follow. You can see the fellow is using the pen to write, and also able to hold a bigger object with 2 years follow. Now we had the IQ Hayasaka to come to our place for our shop, and he introduced us the square flap. This is an advancing square through rotation triangles. This yields 280%, whereas Z velocity gives only 170 lengthening. This is flap is very good for straight band contractures. This is what flap to reflect with the flap. All the sides are equal. You have an advancing square, the 2 triangle flaps. One is at 60 degrees, the other is when you incise and raise these flaps, they will rotate like this. This flap will go to that place. This flap will come. This much widening you get. It's a very good flap for a thumb contractor. I use this for contractors, especially to hand difference in front and any area. This is to show a syndactyly how the square flap is used. The last case I showed you was that I raised a dorsal big flap to create a thumb web here. Here I use the square flap. Square, of course, the square is on the one hand side, triangle flaps on the dorsal side, which I have done now. But a good thumb web, thumb. Be able to hold a pen and write, hold a bigger object of back. The problem is this small fingers here. I told the parents for any toe transfer, they said they wanted them allowed to grow. Once the short fingers grow, it will be because they have a phalanges, they may do a different. It's another case of bidactyl flap. The thumb is again the same level, then is not done. So I used a square flap here, but the web like this. So you can see now the depth of the thumb is bigger than the initial finger. You see here they are. So this is the advantage of the square flap. You will get a deeper. In addition that we are given an opposite split, so that the child whenever playfully he can go and touch the split. So he develop a good opposition. So when you provide a toe or lengthen this, be able to touch the area so that it is very useful. And you see here one more syndactyly, good thumb, web contracture. The problem is all the 3 fingers are buried in the skin. And they all always have the components of the nail plate. Parents always request us separate fingers, none of them to be removed. Instead, we try to do that. We are not hopeful of picking the middle finger. And here the index finger, which is at the metacarpal level, was to see here. The first job what we did was square flap to release the thumb web area. Release the thumb web nicely. And release the syndactyly of the finger. It has been done. And once it has been done, you see here, good verb and good thumb. It has been released. Now we release the little body division here, and then release the small finger and the middle finger. At the end of the day, we got all the 4 fingers nicely. See that you can see all the 4 fingers. Only thing is this is short, small index. And the only idea we want to do an elongation of this finger. We don't want anything. We also don't suggest anything. See the trio. How nicely the child oppose all the fingers. A good span of the web, touch even the small. Then this is the short finger, the last time. Where you could see all the fingers are developed, but the middle 3 fingers are very short. So first thing I did was reduce the syndactyly of all the 3, and then use a local Pre-axial. And I done this distraction 3 times. First in the proximal phalanx, then in the distal phalanx level. You can see I could get up to this level. At the end of the day, the fingers look like this. Child has got all 4 fingers. Of course, they are all the same depth. Somewhere, able to use a pen and write. Parents are happy. They don't want any more mental happy because they have been using Excel for maybe 1 year. They got fed up now with the 6 years. But you see here, all the 4 fingers are same that happy about both the parents and the patients. And finally, the Buncke is a pre-embolic time where no finger is fully developed. It's only the metacarpal hand and small workings all over. And you see here the thumb. The thumb, what you can make out is a small piece of a terminal phalanx. You see that it is within the round, there is a small speck of a bone. So we remove the toe phalanx from here. Then we used to do the thumb first. Thumb is not nicely lengthened. Be able to oppose this thumb to the palm. Be able to also drive the bicep. Be able to grasp the hand with the bicep. This 8 years follow. This they want to do anything, they are actually hesitant because happen to be a left hand hesitating. Now finally coming to the post-axial hand difference. Commonest deformity is ulnar polydactyly, ulnar club hand, mirror hand. Ulnar polydactyly is small like this. You can see many of them hanging around, going around, all together they don't. But you have a case like this where it is coming from the base of the joint. It is always painful. Also, they come at any age they come, they have to do that. Coming to the ulnar club band, it is 1 in 10,000, and this is 4 to 10 times less common than the radial dysplasia. This is the only case I have seen. Orthopedic colleagues, they want to try to straighten this elbow, but it's not possible. The only way to do this is put in an external center and slowly progressively straighten it. And this is a sporadic lesion, always unilateral. The elbow is malformed. Ulna is partially or completely absent. This partial absence will have a fibrous tissue connection, what we call is anal-edge. Unless it is removed, the hand will go for ulnar. Particularly in this case, there was no anal-edge. Thumb is good, and the web is there. Mansky is divided 4 types: normal thumb web, mild first web, and thumb deficiency, moderate and severe thumb deficiency, and syndactyly of the thumb and index, absent thumb. Because it's 4 classifications. Mine comes in A type. There, the plan is to do a thumb reconstruction, release of syndactyly, excision of ulnar anal-edge, and rotation of. But unfortunately, this baby, she needs release of the elbow fracture. And probably I will do that later. First, I advise to go for a forearm lengthening, creation of the one bone forearm. Finally, do an elbow replacement. That is the best for the kid at the age of 15 or so. And coming to the mirror hand, I have seen only one mirror hand in my own practice. This is the hand where you can see there are about 8 fingers symmetrically arranged. and there is two ulna, there is no radius. Fortunately, the elbow was working well, so not to bother about this. Our plan should be stage 1 is pollicization. I don't want to do anything for elbow correction. Unless they come later age, we have to do something. Joy. Now having these things, the radial post was kept as a finger for pollicization. I removed these two fingers, done a pollicization. The good thing is that got a good elbow, good pollicized finger. The child is able to hold a repeat and never came back for anything for without problem. And constriction band syndrome, as I told you, because of amniotic bands have this pattern is classified into 4 types. Simply a constriction ring, what you would show your case, or it can be just like this. It could be a lymphedema, nearly going for a gangrene. Type 2. Type 3 is the constriction rings associated with you can remove that, or sometimes the intrauterine amputation because of the constriction. Here, the other important thing I want to point out, these rings, I use Z-plasty only on the neutral eye. Scar is not very visible. On the dorsum, I always use W-plasty. So you see the end of the day, the scars are much nicer. See multiple fingers, and you see around the thumb. I use the plastic only on the neutral eye. On the dorsum, I use only as plastic. So the scars are much less, not seen. So this is one of the good procedures. The plastic over, and when you do a W plastic, you can do that. Now this is another child brought in at age 4 months. Total constriction. The lymphedema is not very great, and you can see palpate the bone through. So immediately I said it needs admission. To my surprise, when I exposed, there is a bone and a muscle. And both the nerves are scarred. It was held by a fibrous. So we did the fluorography for both. The radial was active to see the child was able to do a elbow extension. Then we did a big Z plastic post corrected deformity. This is now the age of 3 years. I asked the parents to send the video by WhatsApp. See that the child is able to hold the hand, able to flex. See, they came in between. What I did was I put the ECR to the pre-axial for him. Yeah, flexion, but it's not action because of the extension able to dynamic function. But another interesting point I have noted is he's able to hold a big tomato like this. He's able to hold it and keep it in the place. So that means the tendons are working, it's much more. And according to the parents facing some sensation there, which I have to predict, they say that sensation, that means it must have because of doing another repair. And you have some complex problems like what we call is polydactyly. All the fingers are fused on both the hands. So this polydactyly will also have a screw shape. There is a wall of curvature. Full extension is not possible. There is hypoplastic now. So first thing what you have to do with the hypoplastic, then release the syndactyly or release the wall. So pollicization, marginal syndactyly release, syndactyly release of ulnar border, then width and ring. Goes by 4 stages. So I could see here, first I made a radial border, ulnar post, radial post. Subsequently, I removed the ulnar digit, made a pollicization. That worked well. Then I released all that was released. Finally, middle finger and ring finger released. Now you see all the 5 fingers are separated. Able to, though not able to do a tip to tip, able to do this, hold the pen, right, and do everything. See here. What is the difference between the mother and the child? Mother was operated for 20 years ago. The child was operated 15 years ago. Got very handy. Wind blown hand, that's also I've not seen much. Wind blown hand, there'll be a ulnar side deviation of all the fingers. Congenital hypoplastic tendon, which are subluxed at the ulnar side of the knee joint. There is a volar contracture of the thumb web contracture. So the volar contracture, thumb web to be released. Same time, it can also do a circulation. Tendon transfer leak here, which is always missing. So this is what we did. In one stage, we have corrected all the release the palmar web contracture. Then on the dorsum, we release the subluxated extra to the place and fix the PIP joints. Once we have done that, all of them are steady like this. Finally, we had a hand like this. Minimal contraction on the volar side, but the fingers are good. Why is able to use it? The only case I have seen like that. Coming to the macrodactyly, the digital nerve oriented benign neurofibromatosis. The incidence is 0.2 per 10,000 births. There is hypertrophic digital nerve adjacent soft tissue. If one digital nerve is involved, there will be a clinodactyly. Common digital nerve is involved, there is a divergent clinodactyly. What you need to do is a radical excision at the digital nerve. If the digital nerve could not be spared, you can do the nerve entry side available now. Growth plate excision or stapling can be done with vigorous growth of the finger. This is one case where you see here there is a swollen thumb and also the index finger, which is also evident clinodactyly because it's involving the real side of the distal nerve on this index finger. So the X-ray shows here, and also the MRI shown here. Then we release everything. Radial side. Totally removed of the suture. Finally, all the wounds have been child is able to do. The point what I want to mention here is that the child has got a straight finger. The right side also receives. The thinning has not been great, but the clinodactyly has been. That is what advantage is. This is a case thumb index finger. I opened this, released thumb there, released all these things. And I have to exercise all the distal nerves to the thumb radial border and also once I have divided, nothing else to do, just to correct those then to side to get them again. And finally, this is the case first I showed you. We have back to back finger has been operated. Final picture I showed you. Got married, she's very happy. Even these bulges I want to reduce, he said, no, I'm all right. Got married. Finally, the transfer starts. The congenital amputations, the rudimentary disease, the truncation happens because of the loss of area. It may be complete, proximal, or distal. The common site is proximal third of the forearm. And when this happens for a child like this, unless the child comes to a sitting posture, we don't provide. At the age of 2 years, we convert to a body powered body. At the age of 4, we may and I given to them. And after that, they get that. Having presented you all these things, finally, I want to show you a person who has a bilateral congenital. See here, right hand, only a slipped shoulder joint, the elbow which reflects, and the left side got only one. And this is aged about 30 years. And everywhere, nobody would have done anything. He started working with his feet, mainly the left feet, put to be able to write. You see how nicely he's able to butter the chair. no problem. So the nature gives the man what he needs. You correct it, knowing what the problems have shown you are very much simple, which is correct, just to be correct. But these type of problems, see how he is writing. And he is a double postgrad. He has done MA and MPhil, working in a nice, beautiful handwriting. Able to see that he has finished MA and MPhil class. Finally, see, I told him I can't do anything. Now you have already done the best. Be happy with this. So we do a lot of reconstruction. At the end of the day, nature gives the best for the patient. Thank you very much for the patience. Thank you.
Wow, Professor Balakrishnan, thank you so much for that wonderful, wonderful talk. It's really a tour de force of congenital hand surgery, and I think and I just really want to comment on the incredible amount of experience that you've shown in just 1 hour, and it's really amazing. I don't think there are too many people in the world who can give a talk like you did with so much experience and be able to summarize essentially 40 years in about an hour. So thank you so much for that. I also want to thank some valued guests. So we have Professor Venkataswamy here with us. We have Professor Sabapathy with us here. We have Professor Venkatramani. So thank you so much for joining us during this wonderful talk. Professor Balakrishnan, I have a couple of questions for you.
Please, please go.
Yeah, clearly, you know, to get the amount of experience that you have had, you need a very wide referral base for patients to come from far and wide to Chennai to be to see you. Can you comment on how large your referral pattern is and what parts of India patients come to see you?
Of course, as you rightly said, I get patients around the whole country. The reason why I got all these patients was because I worked in a public hospital for 30 years, where the total expenditure is free of cost. So I used to get lots of patients. So these anomalies also happen mostly middle or low middle class people. So they were able to reach the hospital, public hospital. I had a very big experience there. Again, starting a private institution, because of my already what I have done, people have told other people. Only the word of mouth, I get referral. And many times, most of my orthopedic colleagues, they refer patients for correction of any of these departments. So still it is going, and it still go ahead and look forward for correcting many departments. I pray that none of them will get the congenital hand difference. If it happens one, I'm very willing to correct this department.
Now, it's very obvious watching your talk that there has been an incredible amount of preparation for each case. So every case you've shown, they're very complex. And as our dear friend Scott Levin always says, the only shortcut you need is preparation, or preparation is the only shortcut that you need. So I think it's quite obvious that the amount of forethought and planning that it takes to carry out these complex operations. Do you have any advice to young hand surgeons who are aiming to go into the field of congenital hand surgery? Any advice from you?
Not as advice. The main thing is they should try to see many cases. What they should evolve is that what is the main thing? As I told you earlier, is the thumb which has reconstructed first. Next goes to the rest of the hand. That's what we always say. Try to create a radial and ulnar post. How best you can do depends on the particular case that you have to develop. And again, getting trained in an institution like what I have tried in Stanley, that the most useful to me for me. Actually, my professor also here, I learned a lot from him. And then on my own, I have been doing so many things. Pre-phalangeal transfer all I have done because of the workshop what we have conducted in Chennai. I took the lineage from Alan Gilbert from France.
Great. No, that's fantastic advice. And I think that this video of your lecture is going to become required watching in the future for anyone who wants to go into the field of congenital hand surgery. And I want to thank you again for taking the time to share your experience with us and for allowing us to be able to record the session and post it on our educational website. So thank you so much for that.
Thank you. No bad. It's very nice of you. I feel honored to come and do this presentation. I'm very happy if you have enjoyed, others who have all seen this. And I hopefully now that we are going to produce a video, it will be useful for many more people who are not able to attend this presentation. Thank you so
Yes.
much. I feel honored also.
Thank you very much again for honoring us, and I hope to be able to see you hopefully soon in person over the next year or so.
Sure, yeah, please. Not this Corona time. Probably,
Yes,
probably next year or a year later.
Yeah.
Thank you.
Again, thank you so much. You have a great night.
Bye.
Bye, everyone.